Hello everyone, Dr.CHIRAG, second year general surgery resident from Games Push. Today we will learn about MRCP. MRCP is its full form is magnetic resonance cholangiopancreatography. Today we will learn about this in detail. First is definition. MRCP is a non-invasive MRI-based imaging technique that visualize the biliary tree and pancreatic ductal system without the need of contrast injection into duct. It uses heavily T2-weighted sequence in which static or fluid-containing structure like bile and pancreatic juice appear bright. No ionizing radiation or no endoscope is inserted, unlike ERCP. If we talk about its principle, then it's a T2-weighted MRI sequence. Stationary fluid, bile or pancreatic juice give high signal intensity, and solid tissue appear darker. The ducts are visualized as a bright tubular structure against dark background. Optimal optional 3D reconstruction for surgical planning. In this, we can see intrahepatic bile duct, right and left hepatic duct, common hepatic duct, gallbladder and cystic duct, common bile duct, pancreatic duct, main and accessory pancreatic duct, and ampulla of bladder. Its indication is to visualize biliary system in case of choledocholitis, biliary stricture, benign or malignant. Primary sclerosing cholangitis or biliary atresia in infants. Post-surgical anatomy assessment like post-cholecystectomy or stricture or bile leak. Preoperative mapping for hilar cholangiocarcinoma. And we can see the pancreatic system also, like pancreatic duct stricture or dilatation. Chronic pancreatitis or ductal changes, MPD stones, pancreatic divisum, pancreatic cystic lesions or communications with ducts, or preoperative evaluation in pancreatic tumors. Other uses are like assessment before liver transplant for donor or recipient duct anatomy. Evaluation of post-ERCP complication when invasive procedure is risky. Its advantage is it is actually a non-invasive procedure. No endoscope, no catheter into ducts, no ionizing radiation. Can evaluate ducts beyond obstruction. Good for patients unfit for endoscopy or anesthesia. Good for surgical planning also. If we talk about its limitations, it has lower sensitivity for small stones compared to ERCP or EUS, endoscopic ultrasound. We cannot perform therapeutic intervention like ERCP can. Image quality in this procedure, image quality actually reduced in case of patient motion, ascites, obesity, present of surgical clips or metallic implants. If we talk about its contraindication, then absolute contraindications are non-MRI compatible pacemakers or implants, ferromagnetic aneurysm clips, cochlear implants, certain metallic foreign bodies. Then relative contraindication are severe claustrophobia, first trimester pregnancy use only if it's essential. Severe renal failure if gadolinium contrast plan for additional sequence. Inability to lie still or breathe hold. Then if we talk about preparation, in this usually needed 4 to 6 hour fast before the scan to reduce bowel peristalsis or fluid in stomach or duodenum. It removes all or it has to be remove all metallic objects. If we can give antispasmodic drugs, for example glucagon or hyoscine, that may be given to reduce motion artifacts from bowel peristalsis. If we talk about procedure steps, then patient has to be supine in MRI scanner, heavily T2-weighted sequence acquired in coronal or axial planes. 3D thin slice sequence reformatted in multiple planes. It needed additional T1 or T2 fat suppression or dynamic contrast enhanced sequence for surrounding structures. In MRCP report, it includes basic structure. It includes technique like T2-weighted MRCP, 3D reconstruction, additional sequences if done. In reports, it include biliary tree finding like ductal dilatation and with measurement, presence of location of filling defect for stones. In case of stones or tumors, stricture, length of stricture and morphology, anatomical variants, and evidence of extrinsic compressions. In JB finding stones, wall thickening or masses or sludge. In pancreatic duct finding dilatation, stricture, division, communication with cystic lesions. In adjacent structures, liver, pancreas surrounding vessels is if evaluated. In common MRCP findings are CBD stone, bright duct with filling defect with upstream dilatation, or in a filling defect seen as dark signal where no fluid is present or no bile is present, if we can say. Benign strictures are look like smooth tapered narrowing. Malignant stricture are irregular or shouldered narrowing. Primary sclerosing cholangitis, multiple short stricture and plus bleeding. Pancreatic divisum, non-communication between dorsal and ventral ducts. If we talk about MRCP versus ERCP, if we compare MRCP and ERCP, MRCP is non-invasive while ERCP is invasive. MRCP is not therapeutic, it's diagnostic. ERCP is therapeutic plus diagnostic. There's no major complications in MRCP unless MRI risk. In ERCP, there is the chances of pancreatitis, bleeding or perforation. In MRCP, we can visualize beyond the obstruction, while we can't visualize beyond the obstruction in ERCP as there is obstruction. As endoscope could not pass beyond obstruction. We cannot detect small stones in MRCP, while we can see every ERCP is actually gold standard for small stones detection. There is special variants about the MRCP also, which include secretion enhanced MRCP, in which secretin is given IV, which stimulates pancreatic juice. Therefore, we can get better visualization of pancreatic duct and side branches. There's 3D MRCP also, in which thin slice plus post-processing, and we can get surgical planning due to that. That's all we can say about MRCP. Now we will see a few pictures or MRCP diagrams.